Oh, well, welcome everyone. I'm so excited that you're here. I really get excited about talking and introducing those that aren't familiar to child life. My title is Child Life Specialist. I have been a child life specialist for over 20 years now, and I get excited when I get to, like I said, talk about it. And Miss Marini here, I've known her for quite some time. I mean, I'm excited that she even brought me on to this panel and conversations and being able to talk about child life. So please know I really do like questions. I like people to really learn and gain information from this presentation, and also giving you an idea of something you can do outside of the world of teaching. I know a lot of us jump into like child development and psychology and other areas and go into teaching or preschool. And this is another avenue that you'll be able to go into with a child development degree, psychology degree, and like liberal studies, different areas like that. Okay, so I'm going to share my screen and move into this presentation for you all. Okay, so we are going to talk about child life. That's what we call it in an abbreviation world. When we don't want to say the whole title, we'll introduce ourselves like, hi, I'm with Child Life. So that way it makes it a little bit quicker. So my objectives today is definitely define child life services for you all and the role of a child life specialist as part of a multidisciplinary team. Understand how child life specialists help children cope and adjust to hospitalization, and also child life in the community. Oftentimes, child life specialists have been seen in the hospital setting, but we are branching out into the community, which is something really exciting that is new this year. So we're going to talk first about child life specialist role. And I'm going to give you an overview, some understanding of our educational background, different therapeutic interventions that we provide for patients and families to help them cope. And I'm going to talk about preparation support, which is another component of what we do, along with grief and bereavement support. So these different components are what we do as child life specialists when we're working in the hospital and in the community to help children cope and understand illness and their diagnosis and adjust to being in the hospital. Our main goal as child life specialists is to help improve stressful and traumatic experiences. Oftentimes when children are hospitalized, they have a type of a regression. When people think of regression, they think of like, oh, a 5-year-old who now may be presenting as a 3-year-old wearing diapers, sucking their thumb. But there is this emotional aggression that occurs as well for teenagers and older children. And that emotional regression is the fear that can come from the unknown and not understanding what's going to happen while they're in the hospital. So we want to help continue with their development and their well-being when they're in the hospital. Our background for education, child life specialists have a bachelor's degree in psychology, child development, and other related fields. Most child life specialists go the route of child development because it really helps us to understand where children are chronologically, also developmentally, and looking at the social emotional as well as the emotional component and the physical component of where children are when they're developing. Using that development helps us have a starting point of where children are, because in the hospital, we see children not by their age, but by their coping and their ability to, or how they're adjusting to the environment. Because age is just a number when children are in the hospital because of that fear or that component of the unknown. Many child life specialists also have a master's degree. That master's can be in child life. There is a child life master's program at different hospitals. But also you can go and get a master's in human behavior or human development. My master's is in human behavior because I wanted to be very broad with the ability to do different components of child life and not just child life, but also step out into the community, also work with children that are dealing with more psychosocial issues where we're maybe suicidal ideation, and also working as a professor, which is another component of what I do. To be a child life specialist, there's a practicum that's preferred, but it's no longer required. A practicum is a place where you can go into the hospital and gain experience and knowledge about what a child life specialist does, and kind of be a day in a life of a child life specialist where you would shadow a child life specialist for this amount of hours. I want to say it's about 2 or 3 months. And then the requirement is to do a 600-hour internship. This internship is unpaid. This is where you learn the nitty gritty of being a child life specialist and how to speak to children, how to approach children, how to do assessments, how to gain understanding on doing diagnosis teaching, which is another component of what we do. And like I stated earlier, most child life specialists are located in the hospital setting. But as of this year, we were able to get a bill passed through the state to allow child life specialists to work with children experiencing traumatic grief and loss in the community. So I just recently started a private practice, Marini. And in that private practice, I work.
Amazing. We need
I
to talk.
know. In this practice, what we are doing now is working with children that are experiencing traumatic grief and loss. And recently, I'm sure you guys are aware, just to give you an idea of what type of children we're working with. I don't know if you guys are aware of that child that it was all over the news, where she was 9 years old and her mother had stabbed father and took the children and left them on the freeway. And there was an infant baby that was ran over by a car, and this 9-year-old witnessed all of it. And in that, she was the only survivor out of her family because her mother eventually killed herself. So what we are going to do as child life specialists is we're going in and we're working with this little girl to help her navigate her grief and her trauma. Because when children have traumatic experiences, the only thing they focus on is that trauma, and they're not able to navigate through their grief. And so in the community, we're able to help do this work because a lot of people aren't specialized when working with children, which is something that we do as child life specialists. This is the area of some of the therapeutic interventions, not inventions, because I haven't invented this, but interventions that we do to help children cope and adjust. We do preparation, helping children understand what's going to happen, procedural support, being there with the patient when they're having different procedures done. For instance, I was with a little 4-year-old who was having what we call a dressing change, and they needed to take off all the tape, clean the area, and put on new tape. For in the hospital, tape is one of the hardest things that children experience, but a lot of people think, oh, it's easy, they'll be able to do it. Not the case. So what I do is come in and talk to this little kitty about what's going to happen, what they're going to feel, what they might smell, and provide distraction while we're doing it. It was interesting because before we went in, the nurse was like, I don't think this is going to go very well. I think he's going to be all over the place. I'm like, okay, well, let's go in and see what we can do. We'll do our best. And even the mom and grandma was like, what helps him is you watching a tablet and not really talking to him. And I was like, okay, well, I don't have a tablet. I'm not very much a big proponent for tablets. I like to play and engage with children. So I have this very special toy. I love it. It's a little light spinner. It has all these different things that we can do, like make different shapes. And he was engaged the entire time. He didn't get upset. He didn't resist. He didn't try to kick, move, or scream, which is what we were anticipating. And it was great. And the grandma and the mom were saying, I've never seen him like be so calm. And I'm like, great. It's so wonderful when we see these interventions really pan out and work for these kiddos. We do medical play, in medical play, helping children understand, get an opportunity to touch and manipulate materials, what they're going to see or witness or what they may feel. Grief and bereavement support, dealing with death and dying, the distraction. We also advocate for children. Oftentimes, people think that children and teens can do a lot more than what they can, or don't think they can do it at all, or think that they can do things without medications. So we will come in and explain why we think it's important for them to have certain medications. For instance, in the ED, we get a lot of children with broken limbs. and the doctors don't medicate them very well and think that it doesn't hurt. But when they are manipulating these limbs to put them back into place or to get it in a place where they can put it in a cast, once they get in the cast, then they mold it and they squeeze it and they squeeze it and squeeze it, and they don't think it hurts, but it really does. So we will advocate for additional pain medications. We do special events. Just this last week, I really geeked out because we had Star Wars visitors. I won't say characters, visitors. And we got to provide an event for the children where they were able to take pictures with different Star Wars characters. We had arts and crafts. And I geeked out because I'm a big, wait, go back. I'm a big Star Wars fan. Sorry, I touched something and I went too far. Oh, I don't know what happened. Sorry, let me get out of here. I got too excited. Don't look at my stuff. Wait, this is let me go back. This one thing about Prezi, it kicks you in and you keep going and going and going. So the Star Wars event was great. The kids got to come down. All the children that could come would come, and they got to take pictures and meet different people. And then we also work with community partners like Make-A-Wish and different camps that we provide to help children cope and adjust when they're dealing with different challenges. Now we'll move forward. This right here is an intervention that I have done with patients. It's an emotions vocabulary chart where children can tell me what emotions they may be experiencing. So I'll have them use this chart and pick out all the feelings that they may have been having. So oftentimes children know angry, sad, and mad, but they don't necessarily know about like feeling guilty or anxious or cautious or overwhelmed. So these pictures allow for them to identify some of the feelings they may be experiencing. So I'll have them circle all the feelings that they have. After they do this, and this I worked with a 12-year-old, and I had him circle all his feelings. He was newly diagnosed with leukemia, and he wasn't really talking to people. He wasn't engaging with people. And I really wanted to dive in deep and see what he was experiencing or what he felt. And sometimes children don't want to talk, and that's okay. So we want to use different interventions to help them to express themselves. And this is one of them that I did. After he had this expression, he identified all his feelings, and I had him write them down. After I had him write them down, I broke up this pizza pie and I had him put all of the things that he felt the one he felt the biggest and the one that he felt the smallest. And after he wrote them down, I asked him, why did he feel like that? For instance, he felt disgusted. That was his biggest feeling because of the mouth, that because when he vomited after taking medications, it made him feel disgusted. So after identifying what that emotion was, I had him think of a way that maybe we can make that feeling not so big. And he said, use mouthwash and toothpaste to help the smell when I vomit, and put mouthwash in the basin so that when he does vomit, he doesn't smell mouthwash, he smells the vomit. And so I did this with every feeling that he had. With every feeling that was not such a positive feeling, we found a positive way to adjust and deal with that. So that way, and when he was feeling like that, we can move over here to the next step and keep moving forward with our coping and adjusting. One thing about children, they need to have freak out moments just like their parents. But parents don't want children to have freak out moments. They don't want them to cry. They don't want them to be upset. But in order to move through coping and to get to a place of acceptance and understanding, children need to have freak out moments. Oftentimes, parents don't want them to know that they have cancer diagnoses or to know that they have diabetes. But when children don't know and they don't understand, it increases their fear. So what we do as child life specialists is help them to navigate and work through those fears and understand that they can do hard things. And when we help them understand that they can do hard things, they're shocked that they did it, but it also helps prepare them for the rest of their lives. So that way, when they come across other things that are hard, they know I can do it. This is another activity I worked on with a patient who was dealing with chronic pain, and her parents were separated, and they wouldn't allow her to do a lot of hang out with her friends. She wasn't be able to be independent. She was 15 years old. And so we created this care tag to explain to her parents how she needed to be taken care of, what she wanted her parents to know about her and how she was feeling. And so I had her write this down. After we wrote all these down, and you guys can read them here, I told her, I said, okay, now we're going to share this with your mom. And she said, what? I said, yes, we're going to share this with your mom. I'm going to be here with you because your mom needs to know what it is that you need. We also did another one for her dad, and we shared with both of them. And this created an opportunity for her to have a voice. It created an opportunity for her to feel safe and comfortable to be able to express the things that she needed from her parents. And from that moment on, her parents were able to allow her to be more independent. When we do procedures and we're doing preparation, we explain the procedure, what they're going to feel, what they're going to hear, what they're going to smell. If they're not going to feel it, hear it, or smell it, we're not going to tell them about it. If a child asks me that they're going to be in pain, I will use softer language. I'm not going to say, oh, yeah, it's going to hurt real bad. No, I would say, it's going to be uncomfortable. You might feel some pinching. You might feel some pulling. And I give descriptive words to explain some of the feelings they may have. And for some children that I know that are really, really afraid, Marie, do you have that? Okay. For some children that I know that are really, really afraid, I will let them know, tell me how it feels for you. Because everyone experiences pain differently. And it might not hurt for you, but it might hurt for someone else if that's the language that they're using. But I want to decrease their fear, not increase it. And if I tell them some of the things that they may experience, then that's going to increase their fear. So what I do is I leave the window open. I leave it open a little bit so I can go in and out of that window to give more information if I need to, but also hold back some information and share it afterwards. And what I call that is cleanup. I will share the information of what they may have felt, and I'd be like, oh, really? How did that go for you? So that way they can express it and I'm not giving them words. For some children, if you tell them, let's say, you're going to feel a pinch. I'm going to feel a pinch. I don't want to feel a pinch. I don't like pinching. Have you felt a pinch before? No. Well, then how do you know what it feels like? That fear can take over. As we all know, fear can drive us in many different directions and have many different emotions. So we want to decrease that as much as possible. So this right here is part of medical play. We use dolls and we use real equipment, but we also use toys. So if some children are really, really afraid of the real medical equipment, then we may not use that to start. We'll start with the toys equipment, like plastic toys, and then move into the real equipment. This doll over here has a PICC line. A PICC line is a special IV is what we call it, that is placed in the arm and it can stay there for about 6 months. This is something that children have that are going to have medications for a long period of time, and it allows them to be able to go home, and they don't have to have as many pokes. But this line is placed inside the arm and it goes central here to the chest. And some children get really nervous because the doctors say it'll go close to your heart. When you say close to the heart, they hear heart and it's going to touch my heart, and that can create fear. What we will do is to say it goes right here in the center of your chest, because if I say center of the chest versus the heart, it decreases that fear, but it's still being honest. Something that we do as child life specialists, we will always be honest. If we can't be honest, I'm going to speak for myself. If I can't be honest with the patient, then I'm not able to work with them, because if they ask me a question, I'm not going to lie to them. So I will tell parents if I'm not able to be honest, or if they don't want information, then I will send volunteers, I will send other activities, but I may not necessarily go in that room because I don't want to lie to that child. And we've had parents ask us, well, can you just tell them that this isn't going to happen? Can you tell them that they're not going to have surgery? They're going to go have a picture taken? And that's not something that I can do. I was working in the pediatric intensive care unit, and I had a mom tell her son who needed to come to the pediatric intensive care unit for a procedure. She told him he was going to go to the cafeteria. And then he ended up in the pediatric intensive care unit and he lost it, lost trust in his mom, didn't want to go in the room. And it took some discussing with him and helping him understand what was happening, why we needed to do the procedure. Sometimes your mom may think that something else was going to happen. Maybe she didn't know this for sure, because now I'm trying to rebuild the relationship between the mom and the child. And after that, having a conversation with that mom on the importance of being honest, because this is the results. And now I'm trying to help clean up, and I want to foster relationships between children and their parents. And so I'm going to have that conversation about why it's important to be honest, as hard as it is. And here, when we talk about death and dying, I use the word dead and died or is dying. I don't talk to children and tell them that their brother or sister passed away. I don't use cliche sayings like they went to heaven, even though that may be what some people believe. Children need to have concrete explanations of what is happening to help them understand. Children as young as 2 years old can gain an understanding of what death and dying is, because children are exposed to death as early as one. We all have seen Disney movies. All children watch Disney movies. And in most Disney movies, someone dies. There's not too many that don't. But a lot of people brush over that and don't discuss it. Another example, children play cops and robbers. When they play cops and robbers, somebody's getting shot. And so we want to explain and help children understand what that means. It helps decrease their fear. It helps to understand what the next steps are. For some children, like say 2, 3, 4, it's a lot of repetition and explaining over and over what has happened until they get to a place where they can cognitively understand. They know something is different because they see reactions from their parents. And so we help parents to help their children through the process of their grief. We validate their feelings, and we also let the parents know that silence is okay. Being in the room and being silent is okay. For us as clinicians, being in the room and not talking is okay. Oftentimes, it's our need to want to make things better for people when they're experiencing loss, but sometimes being present is all that someone needs. And so what we do is we want to create memories for families. So we'll create different types of keepsakes. And some of those keepsakes are something like this. We'll do handprints. And this necklace is a thumbprint. We'll take a thumbprint and we'll send it off and get it made into a necklace for a family. We've done hand molds. I also have necklaces that I'll give to a sibling, and the sibling can leave part of that necklace to the patient if that's something that they want to do. So let's talk about communication. Communication is really, really important. Where we start as child life specialists is what's called an assessment. When we're assessing the needs of patients and families, we're going in and asking questions. We talk to the nurses, we talk to the doctors, and we ask a lot of open-ended questions. So that way we get children and families to talk to us, as opposed to us asking them, do you want to know what's happening today? And if they tell you no, then your conversation is over. Instead, I would go in and say, is this your first time here at the hospital? I understand that there are some things that may be happening today. What are some things that are supposed to happen today? And asking them, have you ever experienced a procedure before? Do you know what that word means? And so that way it keeps conversations going. In our assessment, it starts from the time we walk into a patient's room. I walk in that room, I'm looking at what's in the room, what's around the room, who's in the room, where's the patient versus the parent, what's the distance like, because I want to understand the family dynamics. I want to understand if there's any faith involved in this family, what type of I call them artifacts, but what type of, if there's anything in the room, whether it's a Bible or there's a rosary, so that I can understand if this patient has faith or not. Is a child engaging in an activity? Are they going to look at me or talk to me when I went into the room? All of this is based on my assessment and will help me know what my next steps are going to be to help this patient. So when I'm working with patients, I want to provide age-appropriate language so that way they understand. Oftentimes, doctors and nurses, and sometimes even parents, use really big words. So we want to break that down so that they can understand. when a patient is diagnosed with diabetes, most of the time they don't know what that is. So I'll break it down and help them understand what that means for what's happening on the inside of their bodies. Talking about the pancreas and the job of the pancreas, so that way they can understand. And for younger children, I use pictures, I use dolls to help them. Again, asking open-ended questions, simple, concrete explanations, and answer their questions. And honesty, that's missing a couple letters. Answer their questions honestly. If a patient asks me if they're going to die, I will answer them honestly. Does anyone really know when they're going to die? And if I know they're going to die, and if they know they're going to die, I'll be like, well, have you heard any conversations? Has anyone talked to you? And if they say no, then I would have to tell them, well, the doctors and the nurses have given you all the medicines that they can give, but the medicines aren't doing their job to help your body, to take away the sickness in your body. Do you know what happens when you can't take away sickness in your body and your body gets more tired and your body gets more sick? And I try to get them to say the words, but if they can't, I will tell them that that means your body's going to die. I had a patient, she was 16 years old, and she was waiting for a heart transplant. Unfortunately, she wasn't a candidate for a heart transplant, which means that she was going to die. And so she says to me, I'm not a candidate for a heart transplant. And I said, oh, okay. Did you just find this information out? She said, no, I've known for a little while. I said, well, can you tell me what happens to your body if you don't get a heart transplant? She says, I'm going to die. I said, you're right. But nobody knows when that's going to happen. So what we're going to do is keep you comfortable. And the way that we do that is give you medicines and helping her to prepare herself to die. A lot of people, I'm not gonna say everyone, but a lot of people are afraid to die. And so we want to take away some of that fear. And what I did with her was we started painting pictures of what her heaven looked like. We started writing letters to her parents. And I kept those letters until she died, which is at her request. And then I sent them to her family members with the pictures that she had drew. So again, we want to be honest and we want to help parents understand that it's okay to show emotion. Oftentimes parents say, I want to be strong. I need to be strong for my child. But a lot of times what that means is not to show emotion. But when parents are experiencing challenges, it's teaching their children how to navigate emotions, how to express emotions. So we want them to put words to their tears because oftentimes parents will say, I'm good, I'm fine, I'm okay. And they're not. And I want to teach them how to have controlled tears versus uncontrolled tears. So I will talk to them about sharing those tears when they're not like convulsing and not able to talk. When parents are able to talk, those are controlled tears. So explaining to their children, it makes me sad to see you in the hospital. I don't want you to be sick. I want you to get better. And it makes me sad. And that's putting words to tears. We want to limit medical terminology when talking to children unless we're going to explain what that means. For instance, when I talk to children about leukemia and what that is, I will ask them, have you ever heard of this word leukemia? It's a really big word, as opposed to coming in and be like, you have cancer, right? Because when they hear certain words, it doesn't matter what you say after that, they stick with that word. And that goes with parents too. When they hear cancer, that's it, they don't hear anything else. So I want to continue the conversation. So I will tell them leukemia is a really big word for having an infection in your blood, which is what it is. But it sounds a lot softer than saying you have cancer and now you're going to need chemo. So I want to decrease that medical terminology. And we want to teach parents to maintain boundaries and limits. When children get sick, the first thing that families want to do is give them everything they want. They want to make it better. So they go and buy them toys. They go and buy them things that they want. They let them eat things that they don't normally eat. But if this is going to be a long-term need for medical attention, there needs to be boundaries because now you're going to create little monsters because now they're going to expect things and they're really quick about how to manipulate their parents and get what they want. And so I want to teach parents how to parent hospitalized children. That means maintaining boundaries, maintaining the same limits you had before you came to the hospital. If you don't get to watch TV after 8 o'clock, you don't get to watch TV after 8 o'clock. You don't now get to watch it only because you're sick. And on top of that, a lot of attention goes to children that are sick, and the siblings are the forgotten ones in the household. So we want to maintain those relationships too. So we will talk to parents how to include siblings in everything that's going on. And if one child, when the child gets sick and they get everything, and then that other child doesn't get anything, it creates a divide. There's already a divide that happens. But on top of that, when one child is getting all the attention, which is valid and needed, we don't want to add on top of that when now they're getting all these goodies. When we speak to the team, the medical team, we encourage them to speak outside the room. When doctors talk to parents, they say things, and children don't understand them all. Teens understand a little more. But what happens is they pick out scary words, and then they put this puzzle together and it's all jumbled up, and it's not what's really going to happen, but this is what the pictures that they develop in their minds. So we want to encourage doctors and nurses to talk to parents outside the room. I tell the doctors and nurses often, like, they'll say, oh, they're sleeping. Okay, but I know for me, when I'm in an unfamiliar place and someone comes in the room, I'm going to wake up. For children, they may not open their eyes because they don't want you to do anything to them, but they're hearing what's going on. So we want to make sure that we limit conversations that happen in front of them. We talk to the team about not talking over children's beds and not including them in the conversation. Children are our number one. When I walk into a room, I talk to the child first, oftentimes before I talk to the parent, and let that child introduce me to the parent, because that lets them have a sense of control, because they have none when they come into the hospital. And then also, we want to address the patient when we're speaking about them. When doctors and nurses are talking over the bed and not talking to them, it's like they're not even there and they're not a part of the care. And we want them to be a part of their care as much as they can. This is a big part of what we do as child life specialists. Once we build really strong relationships with doctors and nurses, we're able to advocate for these kiddos. I said earlier that age is only a number, and that's a starting point for us, but it's not where we focus. And not all children are going to be cooperative in the hospital. They're not going to say, okay, yes, I'll take that poke. Here, just have my arm. No, there's a lot of resistance because of the fear. But when we address the fear, the resistance gets less and less and less, and children become more and more cooperative when they understand. We want to allow patients to express their thoughts and feelings in whatever way that may look, that we can help in an effective and healthy way. I was working with a 6-year-old who had some swollen testes, and he didn't want anyone to look or touch him. And that's valid because he's probably been told, no one goes down there, no one touches you. And he was angry because he was in so much pain and didn't know how to express it very well. So he was hitting his mom. And I came in, I talked to him, I explained to him, we can't hit our mom, but I gave him something to hit. I gave him a pillow, I gave him the bed, I gave him a stuffy and things that he can hit. I gave him, we made these targets that he can throw at the wall because it was safe. But I wanted to give him that expression, that outlet of those emotions that he was experiencing. I validate and I provide a lot of reassurance for children because it helps them to cope and adjust. And then language is really, really important. We want to be very cautious of the things that we say because children take things literally, even teens. I was working with a 17-year-old who came in the hospital and the doctor told him he had a bug, and that's why he was here. He had a bug in his body. The doctor was actually referring to him being sick. Sometimes, you'll hear, oh, you have a bug, you caught a bug. But for him, he thought he had a literal bug inside of him. And I said, do you think you have a bug inside of you? He said, yeah, that's what the doctor said. I said, oh, there's not a bug inside, but sometimes doctors use that as a reference to being sick. And so we teach doctors and nurses and families how to speak to children so that they understand, and teens. So here are some things straight from patients' mouth, what they say. If they have stitches, I have teenagers that have a spinal fusion and they have stitches all down their spine. And if they get up, they think their stitches are going to open. So Are my stitches going to open? Are they really going to put me to sleep like my dog? A lot of the staff, when they're talking about anesthesia medicine, will say, we're going to put you to sleep. Well, if children have had experience with putting their dog to sleep, they're not going to, they think they're not going to wake up, or putting to sleep is something that's going to make them die. Um, will I become addicted to pain medication? I had a teen who was having a procedure and needed to have propofol, and she was very afraid and she didn't want propofol. When I sat and talked to her about it and asked what her fear was, her dad died of an overdose of propofol. And so she didn't want to have the medication. So I explained to her that this is a controlled environment. The medications that we give are only to help you sleep during the time that we're doing the procedure. I'm too dizzy. I can't get up. This is that fear, because when children have procedures, let's say an appendectomy, it hurts to get up, but they have to get up. And there's certain things that children have to do, and there's not choices. But we want to give them as many choices as we can that are attainable. But when we don't have choices, this is what we have to do in order to get our bodies better. Will I get sick from swallowing dye? Dye is actually I lost my train of thought of what it is. But when children have to have certain type of procedures, we use a medication contrast. Thank you. Contrast. The contrast helps to basically show the inside of the body like a light bulb. But when they hear, we're going to give you some dye, which people tell them, am I going to die from swallowing it? Am I going to die? I get that question a lot when they go to have different procedures done, or if they got a new diagnosis. Am I going to die? And I will put that back on them. Like, do you think you're going to die? And depending on what the response is, will be determine what my response will be. If they say, yeah, I say, well, our goal is to help your body take it better and to help so that you don't die. Am I saying that you're going to die or not die? No, but I'm not going to tell, because I don't know and I can't make that call. And I don't want children to have more fear. So I will give them that question back. Why do they keep taking my blood? I need it. So this is from a little 4-year-old who was a newly diagnosed with diabetes, and we needed to do multiple lab draws. And she thought that her blood wasn't going to keep making itself. So helping her understand that our body makes blood all day long. Will I wake up during anesthesia? This is a big concern of a lot of teenagers and older children. And oftentimes when they watch TV, they see people wake up. So I will help explain to them, like, when your body starts to wake up, it feels like you're waking up during surgery, but your surgery is all done. So I want to finish this with this quote. A child's life is like a piece of paper on which every person leaves a mark. And so as child life specialists, we want to leave that mark of positivity, ability, and confidence, and helping children know that they can do hard things. So let me stop sharing my screen and see if we have any questions.
Thank you so much, Misty. Always so informative and so heartwarming.
Oh, thank you.
And I just feel like it takes a very, very special person to do the work that a child life specialist does. And it's such important work, but I feel like it takes essentially an angel on earth to be able to do what you do.
It's such a blessing. I really am honored to be able to do the work that I do.
Yes. So we have a question. Someone
Okay.
who came in a little bit late, but if maybe you can expand a little bit on the educational and career journey. So what is required, the degree and the hours, internship, and all of that stuff.
Okay, absolutely. Thank you, Talia. I'm blessed every day. So to become a child life specialist, you will need to have a bachelor's degree. Most of us have bachelor's degree in child development. Myself, I have a bachelor's in child development, a minor in psychology, and a master's in human behavior. Some child life specialists strictly have bachelor's degrees, and that's okay. It can be child development, psychology, or any related field. Um, And if you decide, there is a master's in child life where you can get more exposure to different dynamics. I guess I don't know what the I don't have the right word, but like for instance, family systems, grief and bereavement. You get classes directed strictly towards the child life profession. It's not required. Oftentimes, when people get bachelor's in something else, let's see, like an art major, and you decide, well, I think I want to go and do work more with children. You can get a master's in child life and become a child life specialist. In order to become a child life specialist, you need to have 600 hours of an internship. And the internship is unpaid, and it's typically in a hospital setting. And then that is where you learn the bulk of being a child life specialist. You learn the language on how to talk to children. You learn how to prepare children, how to work with children in the hospital. And like I was saying earlier, if you weren't here, there's also opportunity to expand in the community. But there's also child life specialists that work. There's one that works at Chino Police Department, working with children that are being removed from homes. There's child life that works dentistry. There's a lot more child life specialists in private practice, which are going to schools and supporting children, preparing them and their families if they have to go to the hospital or if they are experiencing some type of grief and loss.
Super helpful. Thank you.
You're welcome.
I think in a previous presentation, Misty, you had made the subtle distinction about a child life specialist as opposed to a social worker. So the child life specialist is more the advocate for the child. Can you reiterate that?
Absolutely. So our roles cross often as social work and child life because we're dealing with psychosocial, emotional reactions of children in the hospital. The differential or the difference, I'm trying to use big words. The difference between child life and social work is child life focused directly on children, where social work focused more on the dynamic of the family and providing a lot of resources and community resources for families, whether that's financial or housing or additional resources to help with cope and adjusting. Whereas child life specialists, we work directly with patients and siblings, which is our focus. And we work very closely with the social worker, but a social worker doesn't necessarily will not prepare a child for a procedure and does not do diagnosis disclosure like we do as child life specialists.
Thank you for making that distinction.
Mm-hmm.
Any other questions? Let me just double check the chat.
No worries.
A lot of folks praising you for the amazing work that you do.
It's a blessing. It really is. I
It
get
really
excited.
is.
I've actually moved into a supervisory role, so I pop in and out of the
Wow.
units. Yeah, I pop in and out. I call myself the everywhere girl because I go everywhere in the hospital when I'm needed. But this is why I'm really looking forward to this private practice because I get to work on my clinical.
That's great. And just a little backstory for the folks who were in the session. I met Misty because she was my son's child life specialist at Kaiser years and years ago. My now 10-year-old son, Colson, has a genetic disorder. And so, because of that, he has a lot of medical needs and oftentimes is hospitalized. And I think he was maybe 3 at the time, 3 or 4 at the time.
Yeah, he was
He was
little peanut.
little. I know. Now he's 10. Can you believe it?
I can't believe
Oh
double
my gosh,
digits.
so big. Yeah, fourth grade. So I think that was my first real exposure to a child life specialist. And I remember Misty coming in and really helping ease all of our anxieties and supporting Coco and making sure that he had things to help him feel comfortable, things to help him feel like he was at home, that he, books and toys and things like that. And it really made such a huge difference during the time that he was there. And of course, having my professor hat on, I said, you know what? I think it would be so amazing if you could share your role with my students. And this was well before the pandemic, and Misty came into one of my child development classes at West LA College and did a presentation and brought models and different dolls and different things. And we had a packed house, and you just really inspired so many students who maybe weren't aware of child life as an avenue that they can go into and a way to support children and their families. And so thank you for opening up our minds and our hearts to this wonderful profession
Absolutely.
and for first touching our family's hearts when were there to support my son. So thank
Oh,
you for
Yeah.
that.
yeah.
Hello.
Hello.
Can I ask a question? I'm sorry. My name is Sophia Lokur, and I applied for child specialist because somebody recommended me. I'm inspired by that profession too, and I would like to pursue it, but I'm still in the process of figuring out how I'm gonna do that.
Mhm.
I'm graduating this semester for child development in the spring,
Okay.
and I as I came to finish my education later on in life, so I think that profession will fit me right,
Mhm.
because I feel like I can help a lot of children with that.
Absolutely.
Um, I just maybe you can tell me a little bit and what to do next, and
Okay.
that's it. Thank you.
And you're getting your bachelor's right now, you said?
Yes, I'm graduating on May 17,
So when
18.
you graduate, if you are not moving forward to pursue a master's, you could
Mhm.
apply for child life internships. Excuse me. Although you would have to look for programs that take unaffiliated students. What that means is because you're not in school and you're going to graduate, you have to get like your own liability insurance.
Oh,
When you are in school or in a master's program, that's offered through your school. And
okay.
schools have contracts with different hospitals to be able to come in and do internships. The other thing I will recommend is you doing some type of volunteer work in a hospital. Although it's
Okay.
not recommended, it's very highly reviewed. And the intern that has had experience in the hospital over an intern that hasn't candidate, they're going to take the intern with some hospital experience.
Okay. Okay.
The,
Thank
the,
you.
you're welcome. What's going to be the hardest challenge of becoming a child life specialist is getting an internship.
Yeah.
Internships are very backed up because of the pandemic, because when pandemic shutdown happened, there were no interns. So that was 2 years where it's a backlog of interns. I would
Okay.
say at our hospital, I work at Children's Hospital in LA, we get about 150 applicants a term. So that's summer, winter, spring, and fall. And we take two.
Oh, wow.
So that lets you know how competitive it is as an getting into an internship, and also being willing to relocate if you're able to. If not, it's a lot of patience and waiting and not giving up and staying the path if it's something you really, really want to do, because it's not the job that's really hard to get, it's the internship. And you can't do the job without an internship.
Yes, I agree. Okay. Well, thank you. Thank you for the input.
You're welcome. Also, if you're interested, if you are able to, actually, there are child life assistant jobs
Mm-hmm.
where you work in the hospital and work in a playroom and you provide a lot of play and normalcy for children. That's another avenue to go if you don't work, like do volunteer work. And if you're interested in getting paid at the same time, that's another avenue.
So where do I apply for that? In the hospital website?
Yes, so check out different hospitals. A lot of hospitals are hiring. There's a lot of turnover.
Okay.
And there's a lot of turnover in child life because it's a young field and there's a lot of young specialists that are having babies, getting married, so relocating, and it's the
I've
options.
done all of that. I'm at a point of my life that I wanted to have a nice profession. I mean, to help community, help children, and
Yes.
it's just I just love that profession. I just when I heard about it, I felt like that's for me.
Oh yeah, I understand. I didn't start this till I was in my 30s, so it's
Yeah.
okay.
Okay. Thank you, Misty. Thank
You're
you so much.
welcome. Leticia, to answer your question, most hospitals have internships. All freestanding children's hospitals have internships. What you can do if you're looking for a smaller hospital, go on hospital websites and see if they have internships. If there's no information there, call the hospital and ask for child life. Most hospitals that have a pediatric floor have child life specialists. You're welcome.
Super helpful. Let's see. Any other questions? Do you have any recommendations for programs that aspiring child life specialists can apply to that you would recommend?
For masters,
Universities, yeah. Or
for
even
master
websites that talk a little bit more about it or give resources for those who are aspiring to the profession.
where you can go is childlife.org.
Okay, perfect. I'll put that into the chat then.
Childlife.org gives you a lot of information on the field and also educational programs.
Oh, perfect.
And
A
if you,
one-stop shop.
yeah, and if you need to do online, UC Santa Barbara has an online child life program.
Oh. UC Santa Barbara.
Mm-hmm.
Okay. That's great. See if I can get their website and put that in the chat.
Local programs are Azusa Pacific, Loma Linda, and Laverne.
Okay. Awesome. And so here is, I'll put a link in the chat for UC Santa Barbara Child Life as well. So local programs, you said Azusa Pacific, Loma Linda, right?
Azusa Pacific, Loma Linda, and Laverne.
Okay. Perfect. Thank you.
Welcome.
Okay. What other questions might you have, students?
I'm an open book.
What I wanted to ask is when you talked about the how to deal with their pain after a trauma.
Uh-huh.
How long does it take for a child to overcome that?
I don't think anyone. Oh, sorry. Go ahead.
I know anyone can. It's a long process. I mean, it's not gonna happen overnight. So I was wondering what is longest period of time?
You don't ever overcome trauma. You work through it.
Know.
You work through it and you navigate the emotions that come along with that. What we do, so what I do is help children understand that it's a process, it's a journey, and it's not a destination, and it will always be a part of their lives, but it doesn't have to control their lives. They can control it by understanding when those emotions start to rise and how to deal with those emotions when they arise. When you're dealing with trauma, it affects you for life.
True.
If anyone has dealt with trauma, I know I still navigate the trauma that I had as a child, but I'm able to understand it when the emotions rise and to be able to control those emotions by expressing them. And that's something that children need, is to learn how to express emotions because they're not taught that.
True. Thank you.
You're welcome.
Thank you so much. We're at time, and I know that there are other sessions that are going to start soon, but I really, really want to thank you once again for this amazing presentation. And for students who are interested in the recording, there will be a link sent out to all participants of this virtual workshop series after the conclusion, and it will take you to the Teach LARC YouTube channel that will have links to all of the recordings. So you will have an opportunity to go back and review it if you'd like. All right. Thank you, everyone. So good to see you, Misti.
You too. So good to see you too.
You too.